Good morning, good afternoon, and good evening to all. Thank you very much for joining us here today for the Retina Action Call to Action launch webinar. Today's webinar will be on the theme of inclusion and well-being for the aging vision community. We have an extremely interesting panel to bring to you today, and we will begin to get today's webinar with a short video introducing our call to action. Now, it's our understanding that there's some issues with sound here today, but we will be sending the video in or follow-up email after this webinar. So without further ado, I'd like to welcome Orla Galvin, who will be moderating today's panel discussion. And Orla, it is over to you.
Thank you. Thank you, Fiona. And yes, we will absolutely be able to share that video with the audio included on the Retina Action website and on social media later today. So hello and welcome, of course, to the launch of the Retina Action Call to Action on Inclusion and Wellbeing. There are those of you on the call who are very familiar with Retina Action and those of you who are new to Retina Action. So by way of a brief introduction, Retina Action is a global coalition of civil society organisations, and this includes non-governmental organisations and professional associations, all of whom are concerned with vision health, ageing, caregiving, medical research, and the delivery of appropriate and timely treatment options to patients affected by conditions of the ageing retina. So members of this coalition include Prevent Blindness in the USA, the International Federation on Aging in Australia, the Canadian Council for the Blind, the European Council of Optometry and Optics, and of course Retina International and its members. The partnership has worked together informally for many, many years, and in 2017 decided to formalise and develop a work stream to assist in its objectives of improving the awareness of conditions such as age-related macular degeneration, geographic atrophy, and diabetes-related eye diseases. And very, very importantly, prioritising screening and early detection for people living with these conditions. You can find out more about Retina Action on the Retina Action website, retinaaction.org, and you can follow Retina Action on Twitter, and the handle is actually the reverse, it's @ActionRetina. A little bit of housekeeping. Retina Action is supported through an educational grant from Janssen Global, Novartis Pharma, and F. Hoffmann La Roche. So today we have gathered to discuss the Retina Action Call to Action on Inclusion and Wellbeing for those living with conditions affecting the aging eye, and in particular, age-related macular degeneration and diabetes-related retinopathy. The full call to action document can be found on the Retina Action website at retinaaction.org/call-to-action. Now, we know inclusion and wellbeing are of huge concern for the millions of people affected by sight loss through advancing stages of age-related macular degeneration and diabetes-related eye diseases. We know that in 2019, 9% of the global population was estimated to be aged 65 years old or older, and this figure is projected to rise to 16% by 2050. We know that current estimates of the global cost burden of visual impairment due to age-related macular degeneration is at $343 billion per year. We know that there are over 463 million people worldwide living with diabetes. And of these, 1/3 of these experience diabetes-related retinopathy in some form. And this is a condition that is the leading cause of blindness in the working age population today in many, many countries. However, we are also fortunate to know that screening and timely intervention, it works to improve this situation. And in countries where systematic screening programs have been implemented and timely therapeutic intervention has ensued, diabetes-related retinopathy is no longer the leading cause of blindness in their working population. We also know that many studies have shown visual impairment in older adults leads to functional limitation, poor psychological health, challenges in the management of medication, worse overall health outcomes, and increased healthcare spending. So we know that promoting the visual health of older people is not only a public health priority, but it's also an economic concern. Unfortunately, since last year, the COVID-19 pandemic has further demonstrated that vision loss and retinal diseases in particular are not prioritized in times of crisis. In clinical settings, there have been delays in follow-up appointments, delays in elective procedures, and delays in sight-saving treatments. And we know that vision has been lost. Retina Action is concerned that the restrictions to care and services during the COVID-19 pandemic will further promote decreased physical and social engagement, thus leading to higher rates of morbidity and mortality. And as we move towards a world of digitized healthcare, which has of course been fast-tracked as a result of the COVID-19 pandemic, urgent consideration must be given to the digital divide, which impacts the process of validating and standardizing home health monitoring and care for the aging and vision impaired community. So to safely bring retina patients back to the clinic in order to receive their scheduled sight-saving care and to prevent avoidable blindness and to reduce the associated negative impact on both those affected and their caregivers, Retina Action calls upon governments to 1, develop and where developed, implement screening programs for age-related macular degeneration and diabetes-related retinopathy. 2, to sustain and prioritize screening programs for age-related macular degeneration and diabetes-related retinopathy during times of crisis. 3, to improve awareness on the issues of digital poverty in the development of remote screening and eye health care programs. 4, to prioritize the vaccination of the already vulnerable vision loss community against COVID-19. And finally, to promote the inclusion and well-being of the aging vision loss community. So in launching this discussion, I'd like to introduce our panelists. First, let me introduce you to Dr. Keith Gordon, who has been a board member of and worked with a number of national and international organizations associated with vision, and he is the current chair of the Retina Action. Keith is currently the Senior Research Officer of the Canadian Council of the Blind and is the author of the CCB report, The Impact of COVID-19 Pandemic on Canadians Who Are Blind, Deafblind, or Partially Sighted. And this was published in April 2020, and I'm sure he'll talk us through some of that through our discussion. He is the past Vice President of Research of the Canadian National Institute for the Blind, where he directed all research activities of the organisation. Keith's primary research interests lie in the area of ophthalmic epidemiology, and he is an adjunct professor in the Department of Ophthalmology and Vision Sciences at the University of Toronto, and an honorary teaching fellow at the School of Optometry and Vision Science at the University of Auckland in New Zealand. Next, I'd like to introduce Karen Denton, who has always been a keen student and teacher. Karen is joining us from South Africa, and after having a toddler diagnosed with type 1 diabetes, she was set on a pathway that shaped her life. Having completed studies in general nursing, midwifery, operating theatre, nursing administration, nursing education, psychiatric nursing, and a degree in psychology, Karen was uniquely poised to utilise the varied skills for a 30-year career in diabetes education. During this time, Karen lectured internationally, was chairperson for multiple diabetes-focused organisations such as Diabetes South Africa, Pan-Africa Diabetes Educators, and the South African Diabetes Educators Association. After moving to the Middle East for a further 8 years, where she continued her studies, Karen returned to South Africa and has been delighted to reintegrate into the medical field with Retina South Africa as the AMD ambassador. Next in our lineup is Dr. Juliana Salum, and she is our clinical expert joining us today from Brazil. Juliana is a board-certified ophthalmologist and geneticist, has a fellowship at the Johns Hopkins Center for Hereditary Eye Diseases, has a master's, a doctorate and postdoc in ophthalmology at UniFESP at São Paulo in Brazil, and is also an affiliate professor at the ophthalmology department there. As a clinician, Juliana has had direct experience on how COVID-19 has impacted the clinical setting. We're also joined today by Daniana Rollberg. Daniela lives with a retinal dystrophy and has lost 95% of her vision over the past decades. Daniela is a mother of 2 young adults and leads a very busy life. Daniela has studied psychology and languages and worked in industry for many years. As an active volunteer for ProRetina Germany for over 25 years, Daniela has organised events, conferences and symposia with experts and scientists and invited group meetings for exchange among people with AMD and IRDs. In 2004, Daniela implemented a peer-to-peer counselling office in the University of Eye Clinic in Bonn. And since then, the team has specially trained volunteers, all affected by some kind of retinal or macular degeneration, and has given support and self-help guidance to around 250 patients per year. And last but not least, we are also joined by Mike Smith from New Zealand. Mike Smith is the president of Retina New Zealand, is 54 and has retinitis pigmentosa inherited from his mother and her father. Mike joined Retina New Zealand in 2010 upon returning to New Zealand after living in Brisbane for the best part of 20 years. Mike was elected to Retina New Zealand in 2012 and served for 7 years as the treasurer and elected president in 2019. Mike is passionate about supporting people to get the help they need when they need it. So now that we know who are going to be speaking to you today, we're going to dive right into the first point on the call to action, which is to develop and where developed, implement screening programs for age-related macular degeneration and diabetes-related retinopathy. So Keith, I'll come to you first. Could you tell us about some of the challenges and opportunities you've experienced with the rollout of screening programs? And do you have any insight into perhaps remote or distance screening?
Okay, thank you very much, Ola, and thank you for giving me this opportunity to speak to you today. The program that I'm most familiar with is the one that the Canadian Council of the Blind, the CCB, established about 7 years ago in Ontario, that consisted of a mobile eye screening. When I say eye screening, I would like to define up front what we mean by screening. We feel that it's very important that any screening attempt should involve a complete eye examination. There's a lot of evidence that shows that screening that involves anything less than that misses a lot of pathology, and also tends to mislead people that think they've had a complete eye examination because their kids or their seniors underwent a screening. So our mobile eye screening consists of an optometrist who goes into schools and conducts a complete eye examination with kids in the schools. If any eye disease is picked up, the kid is referred to an optometrist or an ophthalmologist, or if the kid needs spectacles, they're also further referred to an optometrist. So that's the nature of the CCB mobile eye clinic. We are now working with the Ministry of Aging in Ontario to get these clinics into seniors' homes. We have a program that will launch if we ever get over this darn COVID pandemic. It's very, very difficult to go into seniors' homes, even just to visit a relative at this stage. So we will not be doing it until the pandemic is over. But that is our objective. It is a program that fits perfectly into going into seniors' homes where they're not getting any eye care, and where we know that there are lots of conditions that result from that, in particular falls. You asked me to mention some of the challenges and opportunities we've had. To be quite frank, in Ontario, we've had a bit of kickback from, not kickback's the wrong term, but we've had pushback from optometrists who have seen us as being in competition to their business. That's not the case, because everybody that we pick up that needs spectacles gets referred. But the optometrists have not been forthcoming in allowing us to utilize optometrists for our clinics. So we have a limited number of people that apply to become optometrists in these clinics, and that's been our biggest challenge. And of course, COVID has been a huge challenge. Schools have been open one month and closed the next month. Seniors' homes, as I mentioned, are all closed. So it's been, that's been a bit of a challenge. One other thing I was involved with in the past when I was at the Canadian National Institute for the Blind is that we set up a pilot telemedicine program in Northern Ontario. It was set up together with a diabetes, a mobile diabetes clinic. And we did we took the retinal pictures and had them beamed into, in those days it was beamed into, today it's all of course by internet, but it was sent to 4 ophthalmologists across the province, who then read the pictures and then fed it back to the nurse or the technologist that was taking the pictures. If the person needed further treatment, they would be referred to a clinic in a city closest to them. I'm also aware across the north, in our huge Canadian country, we have like hundreds of very, very small villages in very, very isolated areas where you can't actually get in by road or sea. The only way to get in there is by plane. So the cost of bringing people down to have eye examinations in the south is huge. And there are a number of ophthalmologists that have been connected by tele-ophthalmology to small clinics in some of these small villages for many, many years. And there's a huge amount of data that has been collecting on diabetics. It's pretty well all been diabetic retinopathy screening that these doctors have been collecting for years. That's the extent of my knowledge on these clinics. I pass it on to the next person.
That's fascinating, Keith. You know, that traditionally, of course, it was always expected that the population and patients would have to travel to towns and cities to attend their healthcare. But really, in this day and age, it's only appropriate that healthcare goes to the people. And you're telling us of examples where, you know, people have to fly in. That's really fascinating. And, you know, it goes to show that it can be done. Juliana, you're in another part of the world where distance screening and screening programs and assessment and eye exams have to be conducted in unique ways, and getting equipment to various places, I'm sure, has proven challenging. I wonder if you could give us some examples from what's happened in Brazil, and also if I could ask you to give the clinical perspective of the benefits of screening, for example, for AMD screening.
Okay, Brazil has 8 million kilometers square. It's compared to Europe has 10, and we have a population that's 1/3 of it. So it's a very spread population, but it's also very concentrated in the main cities. So when you design a program, it's very hard to reach everybody. So it's been a work of years. Since the 80s, we had this program because we realized we are not able to guarantee access to all the people that need. So we start doing the multirão, that's how we call it. It's a day where the clinic is open, everybody that comes in can be seen. That was done first at the biggest cities, when our university was one of the ones that opened it first. And over time, we had been including those patients in the regular access for the SUS. SUS is the National Program of Health. It's like HNN from UK. So it's free for the patients, and we start to have the to improve the access to all the basic units spread all over the country. But we still have trouble. And during those years, we formed a lot of ophthalmologists that we sent over to many cities all around the country. And they start doing these multirões in their cities, mainly the ones that have trouble with people having access to treatment. So it has been covered all over. And when we go to the Amazon area, there was no retina specialist for many years. I was the first one that did a vitrectomy at the Amazon in 1997. I flew to Manaus and brought all the equipment over there, and I trained a team that is still working nowadays. But many other ideas have been went through those years. So now Manaus has a system that bring all the people from the Amazon state to be examined. But there are also the people that are inland, that are over the forest, and we have a boat over there, a big boat that is a hospital, and it travels through the rivers, and they deliver care and do this screening. So people from my university goes on those boats, and they have programs to access not only AMD and diabetic retinopathy, but also they do surgeries as cataract in those boats. So you have to have imagination to access all the population that are far. And it's very important because treating those patients very early is essential for the good quality of care and the remaining vision for those patients. So for diabetic retinopathy, we do have a screening program that applies the laser photocoagulation, and now it's also including the macular edema treatment with the anti-VEGF injections. And for AMD also, there is still a huge problem in access to those treatments, and also in time framing, even before the pandemic. And with the pandemic, everything has got to be more complicated.
Absolutely. So not only have we heard of planes and flying to bring treatment, we now have boats involved as well. There is definitely a long way to go for AMD screening. And Karen, I might just bring you in there as the AMD ambassador in South Africa. You know, while we're waiting for screening programs for AMD to be implemented and rolled out, what can advocates or what can people do in the interim?
As an advocacy and education group, we at Retina South Africa actually have a three-pronged approach. First of all, to intensify our efforts to bring awareness and knowledge to the full multidisciplinary team, so that when people from different professions come into contact with people who have signs of visual impairment or have families who have visual impairment, they can advise them where to go for screening, where to find the closest ophthalmologist, and be able to access that kind of program. Secondly, we also need to increase our efforts with our funders. we were very successful last year in getting treatment for people with AMD from the private funders. And I think that if we include early screening, pointing out to them the massive benefits that you get if you pick this problem up really, really early, the benefits not only to the patient, and because the funders are so financially driven, the incredible benefits to them, that they are going to save money down the line from the various problems that can occur when people have dramatic vision loss. And then last but not least, to create a massive awareness in the public, and to do this through all media platforms. We have been working together with one of the major movie groups that is on the big screen and also on the small screen, which is very popular at the moment. And we are negotiating with them to run short 15, 20-second messages about the importance of screening for certain target groups, and including, for example, everyone that we would like to target over the age of 40. So that is our three-tiered approach, or three-pronged approach.
That's really excellent, and I really like that approach. So playing devil's advocate here, you know, there are going to be people who would suggest that, you know, if there's no treatment available for everybody, why should we screen all of these people? But we know that all of these conditions that we're talking about are actionable conditions, and they're things that we can do. So Mike, I might pass it over to you, and I think your background screen kind of leads into the answer to this. But what would you say to people who suggest, you know, why screen if there's no treatment imminently available to a particular population?
Your microphone is off, Mike.
Apparently it's on.
We have you
Can
now.
you hear me?
Yes.
Okay, sorry, technical hitch there. So in terms of a healthy lifestyle and making sure that you do everything possible to protect yourself from, or give yourself every opportunity to not, or give yourself the best opportunity to not get, especially diabetic retinal diseases and age-related macular degeneration. You know, a lot of it is about you know, diet and exercise can make a big difference. Obviously, for people who are maybe either having other health problems, you know, elderly people may not be very active because of other health issues, or people like with type 2 diabetes who have, you know, problems with their circulation, sore feet and things like that. They just can't go for a walk. So I thought, you know, there's things that can be done, like especially during COVID, for those who are locked indoors and want to exercise, they can do things like you know, rowing machines or exercise bikes and things like that, where they can you know, exercise, still get some exercise in. Or another one which is really good is in swimming pools, whether it's just putting some kind of a flotation device on and sort of waving your arms and legs up and down and pretend you're swimming up and down the pool, or some places actually have exercise classes in the swimming pool, so the water creates a sort of a sense of weightlessness, so that it takes a lot of the pressure off your you know, any parts of your body where there's already pain, and that makes it a lot easier to exercise. A couple of other interesting things in terms of, you know, obviously we all know, you know, eating healthy is important, but a lot of people, it's really easy to miss some important things. And while we all know sort of sugar is an enemy in terms of diabetes related illnesses and everything, in terms of good health, artificial sweetness can be just as bad. And in a lot of cases, and I'm relying on some expert knowledge here that was told to me, but some of the artificial sweeteners are actually stimulate the insulin levels just as bad, in some cases worse than sugar itself. So you know, sometimes, you know, even though you're eating less calories, you're not necessarily achieving anything from a you know, lowering your insulin levels. So it's actually better, if you can, to sort of try and slowly wean yourself off the sweetness and slowly just use less and less of it. And the other thing that I found really interesting, which I learnt just last year, was actually, you know, the good old fashioned you know, roast dinner or something like that, with its meat and veggies. When you have a large amount of protein like roast meat and lots of vegetables, root vegetables, potatoes and all that, that can really spike your insulin levels as well. And so even though you might think a roast dinner is a pretty healthy meal, it could actually be really spiking your insulin levels. So another tip I had was just eating lots of vegetables, but mostly above ground vegetables, because they're it's the root vegetables which are predominantly higher in carbohydrates. And so yeah, having lots of above ground vegetables is really good for you. And yeah, just do as much exercise as you can, usually 2 or 3 times a week at least. And even if it's something like yoga or Tai Chi or something where it's just very gentle movement, if people are suffering from other you know, muscular issues that limit their movement, that can be some gentle ways of getting into it. But
Absolutely.
certainly, you know.
Absolutely, Mike. And I think it's really clear and really important for everyone to understand that, as you've perfectly outlined there, that the fundamentals of good overall health support your vision. You know, it's been published numerous times over to stop smoking, that for advanced stages of AMD, there are supplements that you can take that mimic, you know, what would be a really good dietary intake, really healthy lifestyle choices to delay the progression of those advanced stages of the disease. And of course, healthy lifestyle modifications have been proven medically and scientifically time and time again to benefit all complications of living with diabetes, but also indeed the advancing of diabetes-related retinopathy. Something that you touched on there towards the end, when I've heard others also speaking about yoga and Tai Chi and the mental impact of living with vision loss and on overall well-being, brings me to another question when it comes to screening and early diagnosis. And perhaps, Daniela, I could address this to you. What are the benefits, or have you noticed any benefits on well-being to those that you've encountered over the years who have perhaps received an earlier diagnosis of AMD than those who have received a diagnosis much later when they've already lost some vision?
Yes, thank you, Ola, for the question. I think it's really crucial to have an early diagnosis, to really have the time to prepare. If there is no treatment, you need the time to prepare to what is coming, and maybe also a little bit to digest and to cope. And for example, get to know practical aids, visual aids, forms of support groups like patient organizations, to meet people who get along well with such conditions can be very encouraging for you. And all this to avoid, in the end, helplessness or panic or even depression if you only learn about your condition at a later stage. And especially for people with diabetes who might be a little bit younger, they can prepare, for example, at schooling education, career planning, family planning, which is really very crucial. And when you learn about your condition at a point where you can still adapt to your situation and to what is coming, what is ahead of you, this is really very, very helpful. And also, as you were mentioning, yoga or things like that to do something against stress reduction and helping to cope with the situation is also very, very helpful.
Yes, yes, absolutely. So what we've learned about when we talk about this first point with respect to screening programs, we know that there are things that we can be doing while we're waiting for the screening programs to be implemented globally, but that all of these conditions are actionable and highlight the real need for screening for AMD and DR across the globe. There are things that we can do with our diet, with our lifestyle, and for our mental health and all of the associated complications. So then that's going to lead into our second point, where we wish to sustain and prioritise screening programmes for age-related macular degeneration and diabetes-related retinopathy during times of crisis. Now, we're not naive that there's going to be challenges here. So I think in the first instance, I'm going to bring a question to Juliana with respect to what happens in the clinic. So while we might be calling out and crying out for continued access, Juliana, could you speak to us about what actually happens on the clinic side of things in the middle of a pandemic, or at the start of a pandemic, at the start of COVID-19, with respect to, you know, the impact on the capacity to carry out work? Was it just the clinic that was affected? Was it just PPE? Or, you know, how are the clinicians affected as well? So if you could speak to us a little bit about that, so that the audience can have a full understanding.
Yeah, easy question this. Yeah, that was a completely nightmare since the beginning of last year. At the first moment, we have to close everything. Even among the doctors, we don't know who got the disease. There was a lot of cases among the doctors also. So we really were not able to continue the clinics. We have to close it. And we have to analyze, to schedule a plan on how to go from there. So what are the important patients? So we start calling the patients, important in a sense of that they have a disease that is a time, that has a time problem to be treated. So if you postpone too much the treatment, that will be a trouble. So for example, cataract surgeries was stopped for a while, and the injection patients with either diabetic retinopathy or the AMD patients, we try to bring them to the clinic with a kind of security, with all the protection possible, and try to promise them they are not going to meet other patients, so with a distance. And even sometimes the caregiver that take care of the patient, they don't want to come to the clinic. So we have to talk by patient to patient to see what are the possibilities. Are they far? Do they have to travel? Will they be able to travel? That was really a task to try to make everything more or less organized, and sometimes send the patients to a local doctor and ask them to do part of their treatment in a easier way so that they don't have to travel. So we have to have a lot of imagination and try to adapt to each of the patient environment and situation. And then time was going for example, the retinal detachment surgeries that we try to keep in the regular schedule, but even that was hard because the clinics were not working in a full employee people. There are people that was moved to work in the COVID clinics. And we don't want those patients to be back to the clinic, the doctors to be back to the clinic, because we don't know if they got infected. So it was really a strike issue. And among those patients, we also had the ones that were into research. That was another challenging issue. For example, we had 2 research clinical trials that I was conducting, and they started January 2020. So in March, when we have the lockdown, we are doing the inclusion of those patients. And they could not travel. So I have patients from many places in the country. They could not travel to the clinic anymore. And we do some distant calls. We send medications over the courier. We contact them to try to keep them in the research. But most of the data from the 3-month follow-up visit, we lost. It was impossible to bring them to the clinic. The 6 months was already still challenging, but we could bring some. And from 9, it was a little bit better. And now we are in the second wave. So we still have a lot of trouble. So in the future, I think when we see the results of such a clinical trial, we will see the data of the beginning, and then we will miss data from month 3, month 6, and then we got data from month 9 and 12. So that's going to impact a lot into the research. And one of the research was for dry AMD. So finally, we are having a new treatment that has been tested for dry AMD, and people are very willing to participate because there is nothing else to treat a dry AMD. And they were exactly the patients that were supposed to be at home in lockdown. They could not come to the clinic. So I had patients with late 80s and even 90s. How would they come to the clinic? Even the people that take care of them, they are not very young. Sometimes they even have 65 or 70. And that was really hard to keep those patients in the trial. Let's see, I think now things are going better. So maybe next trials, we have a better way to analyze those diseases. So it was really, really hard. So there are many kinds of issues. Sometimes one secretary, one technician got the COVID. So oh my God, with whom they got contact with? Shall we call them back? It's incredible the amount of trouble we have. We had trouble that we have not even thought about we could have. And we have to address all this. The gene therapy patients, they have to travel also, and they couldn't. So I have to do some visits in Brazil from patients that are from other countries' trials. So unbelievable.
That's, it's really good in the sense that it's good to be aware of, but it's also frightening and, really highlights the huge number of challenges that those working in the clinic actually face. And, I think throughout, and I think it's a testament to you and your work as well, that you really do have to think outside the box and use that creativity and that imagination to try and figure out ways to solve all of these problems that have arisen, not only because of the remote areas that you need to reach, but also in light of the COVID-19 pandemic. And, I think it's really good for our audience to hear that clinics are working and they are trying their absolute best to come up with ways to circumvent all of these challenges. And it's also really important that those to whom that we are asking and seeking action on the implementation of screening programs for AMD and DR are aware that those of us who are involved in this call to action aren't naive to all of these challenges and are willing to act and think about all of the potential solutions to these problems. Because at the end of the day, the goal is to serve the patient population. And on that, Keith, I know you've conducted a study in Canada, and I was wondering if you would speak to us about some of the impacts on well-being that you've found in the study that you conducted during the COVID-19 pandemic.
Yes, thank you very much, Ola. To start with, actually, I'd like to respond a little bit to what Dr. Salum was talking about. And I think I think the world needs to be prepared for the impact that COVID has had on treatments or lack of treatments. We know that there's been a huge backlog in all countries of people not getting treatment. We have all sorts of anecdotal reports of people having lost vision as a result of not seeing their doctors. And I think we need to be prepared for the surge that is going to come once we get over this. There are, in Canada, we've got reports of tens of thousands of cataract surgeries that have not been canceled. That have been canceled, that haven't been conducted. We need to be prepared for to conduct that over and above the normal number of cataract surgeries. Okay. Having said that, I'll get on to answer your question, Ola, and that is, we did a study back in April to see how the people with vision loss were doing under the pandemic conditions. And we found, first of all, that the stress levels were extremely high. We found that 40% of respondents said they were experiencing more than moderate stress, and 29% rated their stress levels at 7 or higher on a scale of 1 to 10. At the same time, many said they were particularly concerned that the effect of this added stress on their mental health may cause them to become overwhelmed. People were particularly concerned about social distancing. At that time, they were all being given advice as to when they go out, they had to maintain distances from other people. Many people needed sighted guides to go out with them, and they couldn't take the sighted guides out with them under the social distancing circumstances. They were unable to judge the distance from others if they were going to social distance. So if they went shopping, they couldn't tell how far they were from the next person. They weren't able to ask people to help them get stuff off the shelves in supermarkets. And most importantly, these plexiglass divisions were being put up at checkout counters in all the stores, and they couldn't see the plexiglass, and they were not able to communicate with cashiers. So these were all extremely stressful things for people. When it came to healthcare issues, people were very anxious about their ability to access a doctor or a healthcare practitioner, and were concerned that under social distancing and patients-only medical appointments, they wouldn't have anybody to accompany them to the doctor, to the clinic or the hospital. This was a particular concern to people who needed sighted guides. They were concerned, as Dr. Salum has talked about, that their inability to keep their eye doctor appointments would cause them to incur additional vision loss. And this is particularly a particular concern to people who are having regular anti-VEGF injections. Over and above all of this was a concern about their ability to meet their financial obligations. We know that people with vision loss are generally at the lower end of the socioeconomic scale, and those that were working often lost their jobs, or if they were self-employed, they weren't getting the same income they had before. And there was a real concern there about their ability to make it financially. We found that about half of the population had a personal care worker coming into their homes. We know that a lot of these personal care workers are itinerant, and they're being shown with time to be carrying COVID from one place to another. So there was concern about that, but more concerned about half of the people who had personal care workers come in said that the personal care workers weren't wearing masks or other proper protective equipment. And above all, as we look at the future for medical care, and I know you're going to get to this, Ola, but we know that one of the lasting effects of the pandemic is going to be that a lot of medical care is going to be conducted online. And we discovered that a lot of people didn't have access to online devices. They didn't have computers or iPhones. And this was causing them to be more isolated. They couldn't access their doctors online. And generally, it added to the overall stress of the pandemic. I will pass that back to you.
Absolutely, Keith. And those points are, you made the points very, very clear. There has been an overwhelming report of increased levels of fear and stress, anxiety and frustration due to not the COVID-19 pandemic itself, but all of the restrictions that have been implemented to keep people safe from the COVID-19 pandemic. And it definitely appears that, like, globally, in the first instance anyway, that those living with vision impairment were not considered when these restrictions and these rules and government guidelines were put into place. So that's something that we want people to be mindful of moving forward. And you're absolutely right. We also are asking for people to be more aware and considerate of the digital poverty that is present when developing any remote screening and eye health care programs or any sort of e-health or digital solutions, to be mindful of the vision impaired community. I know there's a huge body of people who will speak to the absolute benefits of digital healthcare, and there are those who can absolutely speak to the huge challenges for those in the aging population in utilising digital healthcare resources. But first, I think we'll move to a little bit of a positive note at this point. And Daniela, what I'm going to ask you is to tell us about some of the work that you've been involved in with the AMD community and the use of digital and online resources.
Yeah, thanks, Ola. Inclusion and barrier-free accessibility is very, very important. Inclusion prevents isolation. And with this inclusion, I also want to come back to barrier-free accessibility to public transport, to public buildings, to restaurants, and to event centers, if there may be any events in future. But of course, also barrier-free accessibility to digital tools, to computers, to tablets, to have access to digital meetings, for example. In Retina Germany, we have a lot of digital meetings, which of course are only accessible for people who are digitalized. And we had, back in October, we had a whole AMD Action Week, 7 days in a row, about issues about visual and practical aids, about mobility and things like that. And we really had the impression, on the one hand, that there were a lot of people who were either digitalized themselves because they were digitalized because of their jobs, or they had support from their family members. And on the other hand, there were many people, as we realize also in our local groups, we are also forced now to meet via telephone conferences or Zoom or digital conferences. A big group also really is afraid of technology, and they cannot even have access to a telephone conference, not even to a Zoom conference. And so we really, really need support to educate those people in digitalization, and also to have financing of this education and really help these people to get access, because otherwise they're really isolated. They're sitting at home and they cannot even, of course they can do a phone call to someone, but they cannot really keep up with the group. And we really have a lot of people in the groups who have, we're really like a family, and they really miss each other. And so we really need support for those especially elderly people with AMD who are not digitalized.
Absolutely. And, you know, Germany, where you're based, would be considered, you know, a very forward country, very advanced. But I might just bring in Mike here and then afterwards Karen as well. When it comes to the use of digital platforms for those populations that you might have, for example, Mike, in New Zealand, that might be living more remotely, what is the uptake of digital healthcare there, or are there any challenges? Is there any reluctance for people who are living in remote regions to actually engage with digital health and digital solutions? Mike, I'm going to get you to start again because you're on mute.
Sorry, my bad. I'm sorry, I'll say that again. So the issues that we have here are obviously not COVID related, really. I mean, we had sort of 6 weeks of level 4 lockdown where surgeries were still, I mean, elective surgeries were cancelled, but injections were still considered an essential service. So the anti-VEGF treatments still went ahead. In terms of diabetic screening and all your normal hospital screenings and things, that they've all been going along. I mean, you know, public health system, as woeful as it is, it's not ideal. You might get a screening every 2 years, but it's still going ahead kind of normal. The challenges we have are more with specific groups of people. Sometimes it's not necessarily geographically harder to reach people, but sometimes people within certain cultural communities where they kind of either don't feel that the treatments are being offered or the screenings are being offered in a way that's culturally appropriate, or they just don't feel comfortable about going into hospital situations. So there's a bit more we need to do in those sort of areas, you know, making, like they have done some with taking screenings out to specifically to Maori health organisations, and that's been seen as successful. They're looking at doing, we've got an organisation in New Zealand called iHealth Aotearoa, which is has a very similar advocacy call to what Retina Action has, and so they're looking into all these things and how through the University of Auckland and that they can get some screening programs in place. So it is being addressed. I think the digital issue is possibly still something that's got to be worked on, but you know, we're kind of, it's not so big of a deal because we can actually get to be sort of face-to-face appointments.
Very good. And we're all a little bit jealous of the restrictions, lack thereof in New Zealand now, because you've managed it so well. Karen, I'm going to take that question to you as well, because in South Africa, you've got such a diverse population there as well. And, you know, there's a perception that, you know, oh, if somebody has a mobile device, then of course they're going to be able to utilize digital health, and that, you know, are we under a false maybe assumption, or are some people under a false assumption that people want to utilize these devices? So maybe you could talk us through what the situation and the attitudes are like in South Africa, please.
Once again, we have very mixed attitudes, and as was pointed out earlier, I think by Daniela, first of all, we're dealing with, by and large, an aged population with AMD, for example, and even many of the people presenting with diabetic retinopathy only do so after many, many years. In other words, well into adulthood or early old age, we can say. And this group of people at the moment are actually not very tech savvy. They don't know computers. They find it difficult to even work a smartphone. But having said that, that's one thing that COVID has really spurred. And I find that I live in a retirement village, and I find that here, a lot of people who are very afraid of devices and things like that are beginning to use them, are using them to contact family, to be in touch. And I think some of that is being overcome. But we also talking about doing distance screening and telemedicine and things like that. It is difficult because we also deal with a population who, for some reason, I don't know why, often have a basic mistrust of anything online. And unfortunately, this is exacerbated by the misinformation and disinformation that we have experienced and has escalated in the past year, not necessarily relating to eyes, but it has created a feeling of mistrust and distrust, and people simply don't like anything that is online. They prefer, they'd rather wait an extra year and have the consult face to face. And then last but not least are the financial constraints. Now, interestingly enough, there are more mobile telephones in South Africa than the number of population. In other words, many people have 2 or even 3 mobile phones. But because data is prohibitively expensive for many, many people, they simply don't have access to anything online. The phones are used simply for that phone call. And at Retina, we've actually jumped onto that bandwagon, and we have been phoning every single individual on our database to give them education, to advise them about their families, about the importance of screening for family members, etc., etc. So we've really used the telephone platform extensively, but we really need to increase the use of data and being able to access people that way as well. That I think is going to be the way of the future. Can't hear you now.
Guilty, it was bound to happen. I think, the topics that Daniela, Mike and Karen that you've raised here, we could have a whole other webinar on these points and on the inclusion of the vision community and remote communities and the aging community when it comes to digital and e-health solutions. I think what has come up with a lot of what we've spoken about, the impact on overall well-being and mental health, and Keith, to your numerous points on the study from Canada, it's going to lead us into the point number 4, and it's the call for prioritising the vaccination of the already vulnerable vision loss community against COVID-19. And I think, Daniela, I might just bring you in one last time to find out from you if you have heard of further increased negative impact on well-being for those living with AMD as a result of the COVID-19.
Of course, we heard a lot about all the stress concerning the fear of contracting COVID around shopping and around seeing a doctor and all things like that. And so it would be really very, very much appreciated if those visually impaired people were having the vaccination very, very early. So, I mean, they can move around more freely or more carelessly. Of course, not careless in that way. Of course, they still have to abide to all the regulations and wearing a mask and everything. But it would be really crucial to have, for example, to do, if they can do it on their own, but if they go to the grocery and just see what fruits are there, or have some help and take some more time for everything, and not be afraid to get too near to someone or too close to someone, and just meet friends and family without having always that fear around of getting infected.
Absolutely. So ultimately, Keith, what would be fantastic is if at a regional and national level across the globe, we could have advocates that do what you have been involved with in Canada, and your call for the vaccination. Could you tell us a little bit about that, please?
Okay. For all the reasons that Daniela mentioned and that we've all discussed this morning, we felt it was really important that people with vision loss represent a particularly vulnerable population at this time, and that they should have some sort of priority for vaccination. Maybe not first tier. First tier, you have to go to healthcare workers and frontline responders. But we put out a call to governments to at least make people with vision loss a priority at the second tier of vaccination. So to do this, we wrote, we meaning the Canadian Council of the Blind, we wrote a letter to the Prime Minister, the Minister of Health, the Minister of Disability at the federal level, and then similar premiers and ministers in every province. We have 10 provinces and 3 territories. This isn't an easy country to manage, but we sent a letter to all of these ministers, and we ran the letter in an ad in a publication called the Hill Times that is read by every politician in the country. And in it, we asked that people with vision loss should be considered in a second tier vaccination. And we got responses from everybody we wrote to saying that they would consider it. At this stage, it's a little early to see whether they have in fact done what they said they would. But we think that it made some sort of a difference, at least when they sit down in these committees to discuss who the next group of people to be vaccinated is. Somebody somewhere might suggest that people with vision loss should get some sort of priority.
Absolutely, and that indeed is the call for point 4 today. And, you know, I think everything that we've discussed so far leads us into point 5, that we absolutely must call for the promotion of the inclusion and positive well-being of the aging vision loss community. And I think we'll just touch on this very briefly, and I think, Karen, I'll come to you on this to speak on how and why we should have long life with a healthy vision.
Well, vision, as you know, affects absolutely every aspect of every day for every person. And I was just listening now, and we are lucky in our country in a way because we don't have the vaccine yet, but I believe it's coming soon. But it was, I did read the paper that was published, and although, yes, healthcare workers are tier 1, they will be targeted first. The second tier are people over 60 or 65 and people who are compromised in any way. And I believe and hope that this will include our visually impaired population as well. If not, that is an advocacy program for us. But besides that, I think that every single person with or without vision deserves the best possible care that is available to them at every single level. And we have a wonderful opportunity to educate, to advise, to address problems that have been brought up this afternoon, including physical problems, mental health problems, even assisting with financial advice and assistance with people in how to use devices, how to maybe seek employment in different areas, even in times like this massive pandemic. And I see the pandemic as creating major problems, but as many opportunities for groups like Retina International and groups like this advocacy group. And I think that we can capitalize on that.
Absolutely. I think everything that has been discussed today from all of your perspectives all across the world, with all of your associations and involvement with the retina community and with the aging retina community, it's very true to say, and I'm going to quote Daniela, that inclusion improves well-being. And that is absolutely so true. And we've learned and heard about that today. So I'm going to draw this discussion to a close. I think we could absolutely host many webinars on all of the topics that we've discussed today. There are so many more details that we could get into, but I would like to close with a call to all of you who are participating and listening, whether it's today, a week's time, or a month's time, to share and disseminate, promote and advocate for this call to action at local, national and supranational level to politicians and to policymakers. The full document with all of the real world evidence that you need to support this call to action can be found on the Retina Action website. It will also be hosted on the Retina International website. And if you can't find it through the websites or through the Retina Action or Retina International social media, please do just send us an email and we will absolutely support you in getting the message out there and getting this call to action out there. I think as well as that, the video that we were trying to display earlier will be also issued to everyone who has registered for this webinar, whether they've registered in advance or register at a later date. You will also have access to that. So without further ado, I would like to thank all of our participants in today's discussion, to Keith, to Juliana, to Daniela, to Mike and to Karen, and to Fiona for minding us all so well throughout the whole experience.
Thank you.
Thanks to you, Ola.
Our pleasure to participate.
Thank you very much.
Thank you.
Thank you, Ola, and everyone else. It's been great.
Thank you to everybody for attending for a fantastic webinar. Please, if you have any questions, please feel free to forward them to info@retina-international.org. And very special thank you to Orla for her fantastic moderatorship of today's panel. Thank you all for joining us, and we look forward to welcoming you to a future event very soon. Take care.
Thank you.